everyone, my name is Bridget Folk, and this is my presentation about opioid overdose education and naloxone distribution. Answering the question. My actual research question is, does opioid overdose education and naloxone distribution in Barnstable County have a measurable impact on the overall rate of overdose deaths? Overview. We're first going to discuss the opiate epidemic, its history, how it came to be. Then we'll focus on the AIDS support group of Cape Cod, which is the local resource that I've chosen to overview for this research proposal. We'll address the problem statement, do a brief literature review of what research is already out there, discuss the methodology to answer the actual question, and timeline and resource requirements, and ultimately a conclusion. Right, the opiate epidemic. OxyContin was released in 1996 by Purdue Pharma. The idea of pain became viewed differently in the medical community. Pain quickly became the fifth vital sign. It was required by physicians to ask a pain level when patients were coming in. A quote from the Joint Commission on the Accreditation of Healthcare Organizations actually claimed that there is no evidence that addiction is a significant issue when persons are given opioids for pain control. Obviously that's a little bit controversial, and as the opiate epidemic progressed, people began to view, the prescribing of opiates a little bit differently. Eventually, in 2009, OxyContin became abuse-proof. Quickly, users turned to street opiates such as heroin due to the availability and price. And as of right now, mortality rates of accidental opioid overdoses are the leading cause of death, surpassing that of motor vehicle accidents. The FDA and the CDC are working to tackle the epidemic. Some of their ideas include less medical exposure, less non-medical exposure to opiates, early detection, and access to treatment for addicts. Governor Baker is a real proponent of tackling the opioid epidemic, and here he talks about how opioid addiction is a healthcare issue that knows no boundaries across age, race, class, or demographics. In other words, the opioid epidemic and the disease of addiction does not discriminate. It affects anyone and everyone that has it, and really it's an issue that's really prevalent in my generation, and that seems to be taking a lot of my generation out. So it's really reassuring to have people in politics on your side that are willing to tackle this issue and not just turn a blind eye. So Governor Baker is a real proponent for fighting the opioid epidemic. All right, so the AIDS support group of Cape Cod. They were established more than 30 years ago. They have offices in Provincetown, Hyannis, and Falmouth. I've personally been to the ones in Hyannis and Falmouth, where they provide opioid overdose education and naloxone distribution. They use a harm reduction model. They do provide the service of needle exchange as well. And one of their main priorities is to help individuals navigate complex systems of care, including access to substance abuse treatment and resolving insurance or benefit issues. So it's really bridging that gap between the addict and the health care that they may be seeking. And it's one of the only providers of Narcan on Cape Cod. I went into the AIDS support group for Narcan training, and there are two women that do it, one in Hyannis and one in Falmouth, and you walk in, you don't even have to give your full name. Anyone can come in and receive Narcan. All you have to do is sign up and give the minimal information just for their records and per the requirements of the state, and you'll be trained, and it's really thorough. You learn a little bit about how the opiates affect the receptors and why more people are overdosing accidentally, and why more and more Narcan has to be used to bring them back from an overdose. So it's really the opioid overdose education piece of it is really huge, and supports a harm reduction model for users out there. So it's a beautiful organization to have on the Cape, and it's really the crux of this research proposal and this presentation. Many of the statistics about OEND will be pulled from the AIDS support group of Cape Cod and the people that work there. So, all right. So the problem statement. There are a few problems involved in the opioid epidemic. Number one, people are dying. Young people, old people. Like I said, it doesn't discriminate. People are just dying. And like I mentioned before, the rate of opioid overdose death has far surpassed that of motor vehicle accidents per year. So it's the number one cause of accidental death. In addition to that, bridging the healthcare gap, really providing addicts with access to the healthcare they need, whether it's HIV testing, more harm reduction methods, providing them with safe, with clean needles, or even getting them into treatment. The idea is to, get the addict clean so the problem, it doesn't go away, but it helps to tackle the opioid epidemic to get addicts access to treatment. The impact of the AIDS support group of Cape Cod, we already discussed that a little bit. The role of the Massachusetts Department of Public Health, and the need for more research. Okay, we're going to jump right into a literature review. I've chosen a few articles that I found to be relevant to the topic. The first one is Wally, 2013. And this is really similar to the research proposal being discussed right now, actually. It asks whether or not state-supported overdose education and nasal naloxone programs had an impact on the rate of opioid-related deaths in the state of Massachusetts. So rather than just focusing on Barnstable County, which is my backyard, they focused on the entire state of Massachusetts. They did an interrupted time series analysis using statistics from the Massachusetts Registry of Vital Records and Statistics, Mass Department of Public Health. And, compared to communities with no OEND, there were significantly reduced adjusted rated ratios of opioid overdose reversal due to nasal naloxone. Here's a graph representing communities who did enroll in the OEND. It says unadjusted unintentional opioid-related overdose death rates in 19 communities with no, low, and high enrollment in overdose education and nasal naloxone distribution program in Massachusetts. And as you can see, no enrollment kind of stays the same, while low enrollment begins to peak up in 2007. That's really the point of inflection there. And high enrollment seems to climb even higher. So that's direct evidence over a period of time that enrollment in the OEND program does have an impact on the surrounding area. All right, Logan and Marlott, 2013, focused a lot on harm reduction. And a quote from that is that it's effective in recruiting a larger proportion of afflicted clients and in researching several populations that conventional treatment programs rarely reach. So the AIDS support group of Cape Cod also participates in outreach work where they go out and literally track down homeless people and let them know that they're there and they're a support in the community. And, harm reduction, the most relevant thing I can think of to describe it is that it's really about meeting the addict where they're at. So whatever help they're willing to accept, whether it's the exchange of clean needles or the disposal of dirty needles or a kit to help in their using, or whether it's Narcan. So if they use with someone else, it's just those suggestions of how to use as safely as possible to avoid death, really. So it's about meeting the addict where they're at and really planting the seed that when they do want help or when they're ready to ask for help, they know where to go, and those healthcare options would be available to them. So harm reduction is a really important model to answer this question and to keep people alive. That can also include things like medicated assisted treatment. We've got our local methadone clinic. There are a bunch of doctors that prescribe Suboxone, which is an opioid, to help get off of other opiates like heroin, and those are often used to taper people off of heroin so they can more safely be monitored. That's all a lot that has to do with harm reduction. So, an article published by Stopka in 2017 interviewed staff at locations that offer syringe access. So the study seemed like it was a facility really similar to the AIDS support group of Cape Cod, and it really addressed implications of the Affordable Care Act and how health insurance enrollment was actually higher than expected. So the people at the syringe access program helped addicts to navigate the healthcare system. They helped with health insurance enrollment. They dealt with barriers to enrollment, and they could refer to services, including treatment programs and rehab and detoxes. And, the article, it really encouraged the ACA and how that policy really had an impact, a direct impact on the individual addict receiving help. All right, methodology. So it's really important to gather those statistics, and there are a plethora of electronic databases in which to do so. One of the articles suggested the Massachusetts Registry of Vital Records and Statistics, of course the Department of Public Health, dealing with the classification of opioid-related deaths, and in addition to that, acute care hospital utilization rates, which would be when someone overdoses and they end up in the emergency room or something like that. So gathering those statistics allows us to measure the amount of overdoses that are fatal and that are non-fatal. And, with those numbers we can begin to compare and do some statistical analysis. And then, I think the main variable is measuring rates of OEND. So the Department of Public Health has an OEND program database, and the people that receive the training are users or they're non-users. So that can be classified into two categories, and comparing it like the graph we saw before, comparing it to communities who don't have access to the opioid overdose education and loss of distribution. And then, of course, reaching right into our backyard in Barnstable County and what's offered there. So that really helps to specify the study and make it a lot less broad, so the question is easier to answer, so the implications may be clearer. So policy change could be more direct in affecting, by focusing on one area. You have to think locally to think globally sometimes. And of course, opioid overdose death rates. Compared to the Wally article, we would use annual rates of fatal opioid-related overdose and hospitalization associated with non-fatal opioid overdose in Barnstable County. Timeline and resource requirements. So the study proposed won't require too much, which is a plus. It will involve extensive interviewing of the staff at the AIDS support group of Cape Cod, gathering that statistical data that we just discussed, making sense of the numbers, and the fact that the data already exists. So let's say we're studying the year 2017. The amount of opioid overdose related deaths have already been accounted for and are already in record. So it's just a matter of gathering all of the numbers and analyzing them and seeing what comes of it. So the timeline and resource requirements would realistically only take a few weeks depending on how many people are working on the project and availability of the staff and availability of myself, of course. All right, conclusion. This graph pulled straight off, I think it was Wikipedia. It just is really blunt in depicting the amount of overdose deaths involving opioids from 2000 to 2015. Clearly, the overdose deaths have been on the rise over the past decade. OEND absolutely has a place inside the opiate epidemic. What we're trying to measure here and what we're proposing is to measure specifically that impact and how it really truly has saved lives, and there's the question of how much value can you place on a human life. Let's say the OEND education from the AIDS support group of Cape Cod only saved one person in 2017. Let's hypothesize that. Even saving that one person, the family that would impact, all of the people that knew that person that would impact, the surrounding community in which the person is involved, you really can't. It's really challenging to put value on one human life, and I truly believe that if one person is saved, that's enough, and that's enough to, really propose to do a study like this, because there are countless lives at risk as of right now. There's capacity to affect many lives through more intensive OEND, and that's really the conclusion, and the point I'd like to drive home is that the effects, it's eminent. The effects are, could be exponential with the capacity to train enough people and to get the message out there that OEND is available for friends and families of addicts, for addicts themselves, to reduce the stigma of addiction. And, there's a lot more that goes along with it, but hopefully policy can help to suggest that OEND is quite a solution. And sources. And thank you very much for listening to my presentation. We're hopeful that this type of research can continue to exist, and it really truly has the capacity to change lives. So if it helped at least one person, like I said before, to stay clean and to not overdose and no longer be with us, then it truly was worth it. So thank you very much.